Welcome to this Gimme 15-minute education program for medical professionals. My name is Jennifer Steerfoss and I am the CEO of SCG Health. We opened our doors in 2011 and focus our client services on creating value in healthcare through workflow optimization, revenue cycle management, and strategic planning in this post-health reform world. This presentation is getting ready for the Merit-Based Incentive Payment System, also known as MIPS. This session, along with many others, are available for free as a video archive on YouTube. SCG Health also offers in-person conferences on many topics including quality reporting, compliance, and EMR implementation. Learn more at scghealth.com. One quick legal note. None of the information contained in this presentation should be construed as legal advice. I encourage you to contact counsel if you have any questions regarding state or federal law that apply to the concepts covered in this session. With that, let's get started. You'll have me go through a number of different acronyms that we have in this program, and I think the main one that I want to focus on is actually the main law that started this whole thing, which is called MACRA, and that has to do with Medicare, and that's what the M stands for, and a bunch of other things. So this was passed back in 2015 by Congress to replace a program that we all know and love to hate, which is called the Sustainable Growth Rate. It was part of how we were paying Medicare Part B physicians. And so a number of callers and inquiries that come into SCG Health is whether or not MACRA is just the worst thing to happen to how we reimburse physicians. The issue is, and I'll be really frank, wasn't it worse under the sustainable growth rate? Wasn't it worse from before, where we were looking at 20, 27, 30% cuts year over year, and Congress had to get involved? And as we've all known right now, just the political climate is so polarized that really the question that I've posed here with a picture of a true man-made oil disaster is that I don't think MACRA is a disaster waiting to happen as we stand here in 2017 and figure out next steps under the MIPS program. But I want to remind everyone that, you know what, we used to have a different program, and that program was incredibly broken under the sustainable growth rate. So keep that in mind as we think about it. The other question I get all the time is, what is Congress going to do about this? Do we need to consider the political climate as we move forward in the new Medicare Part B physician reimbursement under this MACRA program? Couple things to keep in mind. Number one is that this was passed by Congress after 2 years of bipartisan work. I really don't think that there's going to be any effort to rip up these railroad tracks. And I do enjoy this quote from Tom Leary over at HIMSS, where the point is that a lot of work went into this from both sides of the aisle. And again, I really am hesitant to say that Congress is going to get involved and undo what we've already created under MIPS. But with that said, I also want to point out, and this has been a really interesting thing, is whether or not the repeal or discussion of Obamacare's repeal is going to have any impact on the program. It is possible, and the reason is that the Accountable Care Organization, or ACO, that concept is actually part of the Affordable Care Act, the ACA. So it is possible that the ACA repeal will have some impact on this program that we call MIPS, which I'll get into a little bit more here next. But it's actually not part of MACRA. The Accountable Care Organization was created under ACA and not MACRA, which was passed in 2015. The only other note that I want to point out is that the gentleman right now who is up for the nomination of the HHS Secretary, which is Representative Tom Price, a Republican from Georgia, he did vote for MACRA. So again, if I want to look at the political aspects of it, he has had critical comments, but those were more about the alternative payment model, so I'll talk a little bit more about that. So let's get into the nuts and bolts of what is this program. So CMS loves acronyms. If you haven't figured out, the Centers for Medicare and Medicaid Services is the organization that's overseeing this program. And we don't call it MACRA. We don't really call it that type of thing. Instead, this program we're calling is the Quality Payment Program, or QPP. And you'll see that acronym more and more as we move along. And under this broader quality payment program that affects Medicare Part B physicians and other clinicians that are submitting claims for Medicare Part B, there are two tracks. The first track, which we're going to focus on in this session, is the merit-based incentive payment system, and I'll touch gently upon the advanced alternative payment model of these APMs. Now, the reason we're just going to touch just on it briefly is because the supermajority of clinicians are going to be reporting under MIPS. Only 5 to 9% are expected to be in these advanced alternative payment models, so that's why I'm not going to spend a lot of time on it. But I do want to point out that approximately 48% of all clinicians that are participating in the Medicare Part B program, or even not participating, they're non-participating but submit claims, they're going to be exempt from participation in MACRA, and I'll talk a little bit more about that. That has to do with the low volume providers. So why does this matter? It matters because the way the system has been set up in the past is we had a number of cuts if you didn't participate in either quality reporting or using a certified electronic medical record or something called the value-based modifier where you're judged against your peers. Those three programs have now been rolled into one, and that is what we know today as the MIPS program. In 2016, all three programs were there and they were each individual cuts. They've now been consolidated, and for the 2017 reporting cycle, it's up to a 4% penalty or a 4% bonus. It is a rob Peter to pay Paul model, so for those groups that are low performers, their penalties will pay as an incentive to those groups that do really well. And I've included here a quote from the former acting administrator of CMS, Andy Slavitt, where he's not necessarily looking to dramatically transform the program in 2017 as it was proposed and then finalized in November. Instead, the goal was to do a sustainable transformation of the program so that this would be something that was predictable and not a great deal of change to the clinicians participating in the program. So to give you an idea a little bit about the program, again, it is a -4 if you do absolutely nothing in 2017, and I'll cover the pick your pace reporting options that you have. But the one thing I also want to point out, and that's this little model here, is that there's also just the money that goes into the program. Starting in 2019, we are going to have frozen updates to the system. So the only way really for you to be able to get any bonuses or honestly market basket updates to the system is going to be going for those incentive monies that are available to you, so doing better than your peers. Now, just as a side note, since I did bring out those alternative payment models, if you are participating in an advanced alternative payment model, it's a different payment system. It's not a rob Peter to pay Paul. Instead, it's actually just a flat bonus. So that's an interesting one to look at. That's, I think, why so many groups have been trying to figure out if they can participate. But as I mentioned previously, right now we're estimating less than 10% of all physicians and clinicians will participate. So why do I keep struggling with this term clinician? It's because we move from the term eligible providers to a new term eligible clinicians. So let me break that down and talk a little bit more about that. Eligible clinicians under the quality payment program, remember we're QPP now, this is going to include all physicians, physician assistants, nurse practitioners, clinical nurse anesthetists, so CRNAs, and then clinical nurse specialists. What's interesting about this is that even though previous programs such as the Physician Quality Reporting Program, the PQRS program, that one included physical therapists, occupational therapists, nurse midwives. In 2017 and 2018, they are considered ineligible. So that's where we move from eligible provider to eligible clinician. And this comes out of a history where we had non-congruent definitions among the what we formerly called meaningful use program for electronic medical records and the PQRS program. So these programs now being consolidated, we have one definition, which is fantastic, but it does mean in 2017 and 2018 that there are certain providers such as physical therapists and occupational therapists that are not going to fall under this program. So the penalty will not apply for them. They can continue to do what they've been doing. It is voluntary for them to submit data. Now there is a new low volume provider exemption, which is fantastic. We did not have this previously. You had to participate in the programs. So if there is a provider that is accepting less than $30,000 for for the 2017 calendar year in Medicare Part B allowables. So this is the total charges, not just what the government pays, but the total allowables. Or they care for 100 or less Medicare Part B patients, they are considered a low volume provider and they do not need to report data to CMS. Now again, they could, it's voluntary to participate in this, and as this program moves to all payer in the future, it's a great opportunity to know how to do this and collect the data. And as I have continued to say, if it ain't broke, don't fix it, keep doing what you're doing. So some things for you to know, some slight changes in definitions, and this new low volume provider, if you fall into that, you will not need to report quality data to CMS to be made whole. Now, I did previously mention these alternative payment models, and so let me just briefly talk about them. There are some key elements that are out there today, and then some forthcoming advanced alternative payment models. We've had alternative payment models for a number of years, but the new program under MACRA is that they have to be advanced. And really what advanced means is that there has to be a financial penalty for not meeting monetary targets. So it has to be what's called both upside and downside risk, meaning that, again, if you don't meet financial budget targets, you would be held accountable financially for that. And that's true for hospitals and physicians. So the programs that are considered to be advanced alternative payment models in 2017 are the comprehensive ESRD model. Today there's 37 organizations that are participating. The CPC Plus model, and I've included over here a very helpful map of where those type of CPC Plus participation clinicians are. And as you can see, there are certain areas that absolutely have a prevalence of CPC Plus participation. When I look at the Comprehensive Primary Care Plus model, it looks very much like what we call the patient-centered medical home. It has some other aspects to it. Obviously, it has downside risks, so if you don't meet certain financial targets, there is a financial penalty for participation. But again, it's an interesting model that's out there in certain parts of the country. The Medicare Shared Savings Programs, Track 2 and 3, you would know those as some of the accountable care organization models, but also the BCPI. There's a number of bundles that are in that. The next generation ACO model, there's only 35 organizations that are participating in that model. And then starting in 2018, there's the oncology care model, the OCM, that has a two-sided risk arrangement with 190 organizations participating today. The one other one that I want to spike out, just because this year enrollment is going on here in 2017, and one that I'm personally excited about, is the Medicare Diabetes Prevention Program. It's a program using the CDC guidelines. And the reason that that one's really important is you have to start your enrollment in 2017, so you have the base year for the data if you're choosing to participate in that one. There's a number of requirements for that program, something definitely to look into if you have a high population of diabetics, especially if a number of them are Medicare. So just a brief overview of what these APMs are. I could spend hours going over each of these, but if you're looking for more information, they are out there on the website, so I'll get to where that is and where you can find more information. So the MIPS structure for 2017, 60% is focused on quality. What you know quality today as is PQRS. IT is all programs formerly known as, but quality is the supermajority of your work. And if you participate the whole way, it's to report 6 measures, and I'll talk about that. And there's different ways to submit the data, and I'll get into exactly how you can do that here in a moment. The second category, that's worth 25%, is advancing care information. You would know that as meaningful use. This is the use of certified electronic health record technology. And then the last one, and this is a new category, it's worth 15%, is your improvement categories. So also known as IA. And this is where you're doing certain types of services that are going to improve the quality of care and reduce cost. So let me break these down a little bit for you. So the first thing is, how much data do you need to participate? Since this is the first year, Andy Slavic came up with this Pick Your Pace is the title of it. I think that sounds like a soundbite, but Pick Your Pace reporting means that you could do a little bit, medium size, or a lot. Testing is your first category, and you would need to report only one measure. It could be a measure in quality in those MIPS or non-MIPS measures, could be the advancing care information or improvement activities, and the data only needs to be for 90 days. Partial years where you're going to do more than one measure, and it could be for 90 or more days. When you get to partial year and full year, they do need to be 90 continuous days. Full year is going to be, again, more than 90 continuous days, and you have the ability to report on all of the measures. The more that you report, the more likely you are to move towards having bonus monies. And I love how they talk about having a small bonus or having a moderate bonus. We don't really know what it is, since it's a rob Peter to pay Paul. We don't know how much money is going to be out there in that bucket. But the more you report, the more likely you are to get those instead of dollars. So let's start with how you can get data to CMS. They have consolidated how they are doing that. So I'll go over some of the options that you have here. If you choose to go claims-based, which is the free model that many folks have been using, your reporting population for your MIPS measures are going to be only Medicare Part B beneficiaries. Remember, if you do claims-based reporting, it has to be reported on the actual claim. You can't do corrected claims to submit the data later. And CMS is limiting the number of measures available. There's only 74 measures that you can report through claims-based reporting. You would then have to do your own upload and attestation information for both the advancing care information and or improvement activities. You wouldn't use a vendor to do that. You can choose to use a vendor to submit data, either a registry, a qualified clinical data registry, or an electronic health record organization to submit your data. If you choose to do that, you are reporting on all patients, all payers, all patients, and that data then goes through with that vendor to CMS. We do not have the list yet of the registries and the qualified clinical data registries. That will be released sometime in spring 2017. Generally, it's available by April, and the list will be posted to the QPP program website, and this is definitely a site to get to know, qpp.cms.gov. I'll show you that here in a second. The MIPS measures are also posted to that website, and again, I'll give you just a quick breeze around there. The only other one that's out there is if you wanted to do, if you're a group, so under your tax identification number, if you have 25 or more eligible clinicians, you can use the CMS web interface. Again, you're reporting. CMS will identify 248 consecutive, there's a whole list, but you have to choose 248 consecutive Medicare beneficiaries that you're going to report on, and you report on 15 measures. This works really well for groups that have primary care in them. They can be multi-specialty, that's not a problem, but you do need to be a larger size group to do that, and there is no cost to participate on the web interface. So before I get over to the category calculation, let me quickly show you the website. This is the qpp.cms.gov website. If you go under Education and Tools, a number of the items that I've talked about are available. So the rule is there, legislation, there's a video archive if you want it. So far, we really haven't used the documents that are under clinicians, but if you were looking for the measure specifications and more information, honestly go to the 4 registries, qualified clinical data registries. You'll find the measure specifications. I'll talk at the next session about the quality benchmarks and what we call MIPS math. And then I'm also, one of the items we've been dealing with is this measure specifications for meaningful use, which we now call advancing care information. Those are here on this website. Alternatively, if at the top you go to exploring measures, you can go in and actually check out all the individual measures and create your own list of each of them. They have the 3 different categories that you can choose. So here's the quality measures, and down here you're able to search for measures. me do this. Let me do quickly that we're going to search for. We were dealing with podiatry for a while. So if we're looking for the diabetic foot exam, you can search for it. So a pretty slick website to check out. They have, as I mentioned, quality measures, advancing care information, and the improvement activities, all as different areas that you can go to. So why, again, does all of this matter? And I'm going to spend our next session going over what we truly are calling MIPS math, and it is higher math. It's nearly calculus. It's kind of crazy when we get into it. But for eligible clinicians in 2017, there's an easier pathway, obviously, to avoid the 4% penalty, which is just submit one measure for 90 days. You can do it through claims-based reporting. You could do it through a registry, qualified registry, or EHR, or if you wanted to, you could do it for 248 folks off of the CMS web interface. So just one measure for 90 days, and then you would mitigate it. But if you're going for the gold and going for the incentive, knowing this MIPS math is really important. So for example, this is just for quality, which is 60% of your total, so this is where the most amount of your points are, depending on the size of your practice. And again, I'm going to go in depth in the future session on this. But for this one, just for example, if you're a small group practice, 15 or less eligible clinicians, it's worth 60 points. 6 measures, 60 points. Each point could be, each measure is up to 10. And then 70 points are available if you are a practice 16 or more eligible clinicians. You're going to ask why. There is an extra measure in there, which is from the old program, the value-based modifier program, which is your total readmission cost, quality for your total hospital readmissions. And again, next session I'll talk about where you can find more information about that and what's out there. There's a number of interesting things here. There's some bonus points that are available, and also there's a minimum threshold of 3 in this first year of the transition. So I'll show you more about that. Really highly recommend that you check that out on the MIPS math session. But there are non-MIPS measures, and we used to call these non-PQRS measures. These are now non-MIPS measures. They're only for qualified clinical data registries, and again, we won't have that list until spring 2017. But here's just some examples. There's some cabbage measures that are out there. So highly recommend, I'll talk more about this on the next session, but also in the spring when we have that list, we'll have another, give me 15 minutes about that. So I want to just turn to the program that we formerly know, Meaningful Use, as it's now called Advancing Care Information. It's worth 25% of the whole. And honestly, if it ain't broke, don't fix it. You will hear this mantra over and over and over again from me. What they've done is that they've taken what you previously did if you were participating in Meaningful Use, and they've modified how you want to get points. There are 5 required elements of these. These include your HIPAA security risk analysis. You have to do e-prescribing. This is one of my biggest problems with most of my doctors. You have to have your patient portal. And then if you are doing transitions of care, you're going to need to do the summary of care and be able to accept summary of care. For many of my specialists, they don't do those transitions. For primary care, you will. But let's say you continue doing what you've been doing, you can get a lot of extra points here. So if you've been doing patient education, that's up to 10% bonus out there. And then if you do participate with a clinical data registry, you're going to get up to a 5% bonus for participating in sending data to a qualified clinical data registry. So some great opportunities. Again, if you go to that qpp.cms.gov website, you can see all of these different categories and pick the ones that are right for you. Now, improvement activities, this is the brand new area. It's worth 15% in this wonderful year of 2017. And a number of these items, guess what, are things that you're already doing and you can get credit for them. So I've spiked out the top 2. A number of states have already required a prescription drug monitoring program if you are prescribing controlled substances. Just signing up for that one gives you a check the mark, and you're able to get some points for that. If you actually consult it and you use it for more than 60%, I'll show you what that states over here. But if you do that, that's a high activity weight, and you get even more points. So I tease that this is an opportunity to get credit for what you're already doing. There are 92 different measures that are out there. More than likely that there's definitely a set of measures that are going to apply to you. It's up to 4 measures that you can report to me. This is a gimme. These are 15 points that you can absolutely get out of it. And then if you're a small group, if you're rural, or if you're in a healthcare professional shortage area, which we also call HPSA, there's additional bonus points available for you. So advancing care information, keep doing what you're doing, and under improvement activities, get credit for what you already are doing. I highly recommend you check that out, again, on that website, qpp.cms.gov. They have the measure specifications out there. So again, you can learn more about these individual measures and the requirements of them. And that is, again, on the qpp.cms.gov website. So your homework in getting ready for MIPS is to choose your quality measures that you're going to report, which we formerly called PQRS. That quality component, it's where the most amount of points are. And then you get to choose how much do you want to do? 90 days? Do you want to do a full year? How do you want to report? But I'd really recommend figure out your improvement activities. Which ones do you want to do? And remember, this is all auditable, so you need to make sure you document what you're doing. If you don't have an EMR, figure out, are you going to adopt it? You have a couple, again, this is a transition year, so you have the full year to figure out what you want to do, so you're ready for 2018. And then I'll talk more about this during the MIPS math session, but if you haven't already, go and get your quality report, or resource use report, quality resource use report, QRUR, so that you can get ready for 2018. There's a great deal of very important data available in that, and I'll talk more about how you can get that information in the MIPS math session. So with that, SCG Health is always available to you as you learn to innovate and improve your practice to deliver affordable quality health care at the point of service to your patients. So I hope that you've enjoyed this presentation. For those of you that are watching the video archive, please remember to rate this video. To receive notices about upcoming Gimme 15-minute programs or other educational sessions, please sign up on scghealth.com. Thank you for joining me for this Gimme 15-minute education program. This concludes the presentation.